Thank you, Dr. Subhash, and good evening to those present in the hall. My topic is cataract surgery in a previously operated eye, and that is after injury repair. There are no financial, I don't have any financial interest, there are no disclosures. The epidemiology is 65 to 80% cases of traumatic cataracts are due to open globe injury. It is common in children and young adults, obviously. Globe injury is mostly in the cornea, limbus or sclera, but it could be posterior segment as well. There could be associated anterior segment injuries, and associated posterior segment injuries may also be present. Most important is the timing of cataract. We traditionally follow 6 weeks after repair, because surgery is easier, the cornea will be clearer, tissue will be less reactive, IOL calculations will be more accurate, there will be a better chances of in-the-place bag placement of the lens. But there is also a study which says that in the primary and the secondary cataract surgery, there was no difference. Now, a preoperative cataract will be slightly different. Documentation and the visual prognosis must be clearly explained. The extent of globe injury prior to management of the lenticular injury must be noted. The presence of lens dislocation, capsular tear, flocculent lens material or vitreous in the AC should be noted. X-ray, CT, whatever, to rule out intraocular foreign body, and determination of the type of the tear or the injury and the extent, whether it is focal or total lens opacity, all these should be noted. Intraocular inflammation must be taken care of, and it should be seen for it, and high IOP also should be checked. Biometry again is going to be a challenge. We may use the other eye biometry if the keratometry or the A scan in the first eye, the injured eye, is not possible. An acrylic single piece or a multi-piece foldable in the bag. But if we are going for the sulcus, then a 3-piece IOL or a single piece PMMA is desired. AC lens, you may, in elderly patients with good iris support, if there is no evidence of glaucoma and AC is free of vitreous. And scleral fixation if the surgeon is competent. But no AC IOLs in children. Capsular management, if the capsule is intact, you can do a CCC, avoiding zonular stress. If it is ruptured, cut away the tags and fashion an opening as close to a CCC that you can make. Old capsular openings will have a fibrosed margin and you will have a relatively easy work. Remove or break the synechia if present. If 30 to 90 degrees zonal dialysis, use a CTR. If more, there are other options of capsular fixation. The Sionis ring, a segment or a glued hook by Susan Jacob. If there's an extensive subluxation, remove the lens in toto and go for a secondary IOL. If there's a vitreous in AC, do an appropriate vitrectomy first. These are a few pictures in which there was an anterior capsular tear. On the picture on the right, you can see that the capsular tear is fibrosed. This is a large subluxation. I doubt if we can reposit the bag in this case. The nucleus management, these are usually younger patients and will have a soft lens matter, and many times it may just be aspirated by an IE or a Simcoe. If a formed nucleus is present, we do a slow phaco, that is by reducing the parameters. If corneal opacity is hampering the view or nucleus is very hard, we may consider doing an SICS, which would be a safer surgery. And if the corneal scarring is gross, then you can think of a keratoplasty and cataract surgery. This is a video, the surgery done by Dr. Subhash Prasad. There's a capsular tear, a synechia. So it's just with a coaxial aspiration, irrigation aspiration, he's aspirating the cortex. And the capsular tear was quite fibrosed, so you all have the opening. It's almost clear. And so he can implant a single piece in the bag. Now he's doing a vitrectomy. In the area where there is a synechia, he's suspecting that there must be some vitreous in that part. This is another case. The iris is torn at one part, trying to remove the synechia and fashioning a rhexis. The needle didn't work. Now with the forceps, being very gentle because the sinews may be damaged, and with whatever opening he has, again by irrigation aspiration, coaxial, he is removing the lens matter. These are soft lens matters, and there is a high chance of vitreous in the injured part. In this case, he is using a multi-piece. Dialing the lens in position and closing the case. Again, this was a case done by me and the microscope wasn't too good. So trying to make a rhexis which is already torn, there's a tear there. So if by one side it does not complete, I change and try to do it from the other side and get a fairly clear rhexis, but that torn part is a bit fibrotic. So my rhexis stops there. And then I have to cut it that part and remove it. This again is a soft cataract, but I'm using a phaco power in this. It's better to be slow and safe rather than see how much time you are taking to do these cases. We cataract surgeons tend to time our surgery more than other things. So this is a subincisional cortex which is going to be a bit difficult to remove. With the bimanual, I try to pull it out. And a multi-piece lens. This was the third day post-op picture, fairly clean. This case had come quite early, just a 3-day-old wound, and here I was in dilemma whether to go for a repair as well as a cataract surgery, but the case didn't turn up when I called him for surgery. The prognostic factors depends on the initial vision. Open globe injury have a better post-op vision than closed globe because closed globe injuries may be associated with posterior segment changes. The location of the wound, and there's an ocular trauma score which gives you a predictability of the post-op vision. Follow-up again is important because these are not normal cataract and these are young patients. Long-term is needed, risk of infection, glaucoma, they may develop amblyopia, PCO, posterior segment problems, and one problem for us is the medical legal. So, to summarize, presentations can be various. Decision making is important. Management of traumatic cataract is challenging. Outcome depends on collateral injuries as well, but usual vision can be restored. Thank you.
Thank you, Dr. Rajan. So, as he said, everything about this, how you approach these patients. And let me tell you that no cases of traumatic cataract are same. Each case has different kinds of presentation, different kind of challenges during the surgery. So each case has to be individualized. Just for the sake of the audience, I just want to know in which cases, if suppose patient comes with a penetrating injury, in which cases would you advocate that you go with the simultaneous cataract and repair?
See, if the flocculent lens matter is in the AC and it's going to cause uveitis and glaucoma, in that case I would like to aspirate it in the primary session itself.
Yeah, otherwise it's always better to do the primary repair so that you have some time for the tissues to heal so that you can plan in a better way. So thank you, Dr. Rajan. Is there any question from the audience?
No, if you are not doing it along with the injury repair, if the cataract surgery is after some days, weeks after the injury repair, then once you remove the lens matter, you implant the lens in the same sitting. No, again, that is what I'm saying. Repair and cataract, whether you do together, depends. But if the repair has been done earlier, then when you're removing cataract, obviously you'll implant the lens at the same sitting.
What I do that if I find that the tear is in the quite periphery and there is flocculent lens matter, I find that that is the best case to implant the IOL in the same sitting. Otherwise, if there is lot of injury in the central part of the cornea, I would rather like to wait for some more weeks, like 4 to 6 weeks at least, so that we can do the keratometry better or plan in a better way. So